Chapter 51, Concepts of Care for Clients with Non-Inflammatory Intestinal Disorders. The priority concepts in this chapter are elimination and cellular regulation. The interrelated concepts in this chapter are nutrition, comfort, and fluid and electrolyte balance. Intestinal obstructions fall into two major categories: non-mechanical and mechanical. Non-mechanical bowel obstructions refer to a bowel that is physically blocked by problems outside the intestine, in the bowel wall, or in the intestinal lumen. Non-mechanical refers to a decrease in peristalsis. This can happen as a result of surgery or a neuromuscular disorder. What is occurring is going to be a backup of the intestinal contents. An example of this would be a paralytic ileus. There are several complications of intestinal obstructions, and that includes fluid and electrolyte imbalances and acid-base imbalances. And this really depends on where the blockage is located. Obstructions that are high in the small intestine will cause a loss of hydrochloric acid, and that's going to result in metabolic alkalosis. Obstructions at the end of the small intestine are going to cause a loss of alkaline fluids, and this is going to result in metabolic acidosis. If there is a strangulated bowel, the risk of perforation is going to be increased. Perforation is going to lead to peritonitis that can result in septic shock. Intestinal obstruction can have many causes. If it's a mechanical obstruction, it can be caused by adhesions. You think about clients that have had multiple abdominal surgeries, they're going to have adhesions in there and scar tissue. That can result in a mechanical obstruction. Tumors can also be the cause of this, hernias, fecal impactions, strictures. This is up here is an example of one that's an intussusception, where the bowel is telescoping in on itself. And this one right here is a volvulus, where you can see that the intestine is actually twisted. Non-mechanical is again due to a decrease or absent peristalsis, and that could be caused by an ileus. This can be due to a neuromuscular disorder or surgery. And when you think surgery, it's not just bowel surgeries, although it's going to be more likely for a bowel surgery. Any type of surgery can cause a decrease in peristalsis as a result of the sedation that's being used and any follow-up pain medication that's going to be used for the client post-op. For your assessment findings, clients with mechanical obstructions in the small intestines are going to have mid-abdominal pain. This is typically going to be cramping in nature, and it's going to come and go. So when you're doing your thorough pain assessment, they're going to tell you it's going to come and go, and you need to make sure that you're asking them what makes it better and worse. If strangulation is present, the pain is going to be more constant. Clients could have vomiting of bilious materials. Just keep in mind too, it's not just bile, it's anything that's in the intestine that could be coming up. So that includes fecal matter. So they could be vomiting up fecal matter. Just keep that in mind when you're thinking about what your interventions are going to be for this client, because oral care is going to be pretty important. If there's a partial obstruction, there could be diarrhea, where the diarrhea is actually moving around the obstructed area. And then obstipation refers to no passage of stool and failure to pass gas, and that is called flatus. If your client is experiencing colonic obstruction, they're going to have lower abdomen pain, and that's going to be a colicky type of pain with cramping. And no matter where their obstruction is occurring, they could have abdominal distension, and that may be present with peristaltic waves, so you might actually see those visibly from the outside when you're doing your inspection. Borborygmi, that is going to be your high-pitched bowel sounds, and these are typically associated with cramping. They may be heard early in the process, and then as the obstruction progresses, it's going to become more distant and even absent. If a non-mechanical obstruction is present, then the pain is typically constant and widespread. If the obstruction is vascular in nature, the pain is typically more severe and constant. For diagnostic assessment, we really want to make sure that we're looking at their fluid and electrolytes, because remember, we're dealing with the GI tract, especially if they've had a prolonged illness or nausea, vomiting, and diarrhea. We may also want to check a CBC to look for elevated WBCs, H&H to make sure that they are not experiencing a bleed. And to check their electrolytes, we could be doing a couple different studies. We could be doing a CMP, would be more comprehensive, BMP is more basic, and then a RFP, which is a renal function panel. In severe cases where an acid-base imbalance is suspected, they may also draw an ABG. Just keep in mind that these fluid and electrolyte imbalances or acid-base imbalances may be present depending on the location of the obstruction, if vomiting is present, and how long this has been going on. Imaging is going to most often involve an abdominal CT or an ultrasound. They may also order a KUB, which is an abdominal x-ray. KUB stands for kidney, ureters, bladder. And they may also perform an endoscopic procedure for more direct visualization of the problem. The priority for these clients is going to be to prevent complications. There's a high potential for injury, not just from perforation and peritonitis, but also think about the fluid and electrolyte shifts and the shifts in the acid-base balance. Additionally, we want to help control their pain. So really here, think about your pharmacologic and your non-pharmacologic interventions. The type of obstruction and the severity of it is going to drive the interventions and the treatments for this. Sometimes the treatment can be pretty conservative and they may do an NG tube for decompression. The clients are going to be NPO for bowel rest, and depending on exactly where the obstruction is occurring, they could be also administering an enema or some laxatives if there's obstipation. IV fluids are going to be given, not just for the NPO status, but also to replace any fluids lost during vomiting, dehydration, diarrhea, and then consider electrolyte replacement as needed. Positioning is going to be really important with these clients, so semi-Fowler's position, and then raise the knees up as well, and that's going to help alleviate any pressure on the abdomen. Surgical interventions are varied. They could be as simple as an exploratory laparotomy. It could be removal of a tumor, untwisting of the bowel, release of strangulation. It really depends on what's going on here. Then moving on to colorectal cancer. So this image here is referring, like the percentages here are referring to the incidence of cancer in relation to the colorectal anatomy. So it kind of breaks it down so that you can see where it's more prevalent. So the highest here is going to be 30%, which is a rectal cancer. And you can see the numbers throughout. Colorectal is going to refer to the colon and the rectum, and which together make up the large intestine. So colorectal cancers are going to be a major health concern worldwide. If they're caught early, the survival rate is really good. About 2/3 of these cancers occur in the rectosigmoid region. Most of these are going to be adenocarcinomas, and that means that they arise from the glandular epithelial tissue of the colon. Many of these are also going to arise from polyps. Major risk factors for colorectal cancer include being over the age of 50, familial history, polyps, and Crohn's disease. For physical assessment, if you remember from the oncology section, we talked about the acronym CAUTION, and one of the signs in there was unusual bleeding or changes in bowel habits. So those are going to be indications here. The American Cancer Society recommends FOBT or fecal occult blood test yearly to screen for colorectal cancer. So bleeding and a change in stool are going to be the most common signs. You may also, in more severe cases, see a visualization of the tumor, like in a bulge in the abdomen. That's why we do our abdominal assessment. We actually visualize the abdomen. And then bowel sounds are going to be either absent or high-pitched, and they may have peristaltic waves. And then think about it too, if they have an obstruction at all, they could have all the signs and symptoms that we discussed previously when we were speaking about obstructions. For labs, we can conduct a fecal occult blood test, FOBT, or a carcinoembryonic antigen, our CEA test. And then don't forget about our CBC and our CMP here as well, especially if they're having bleeding. For imaging, sigmoidoscopy or colonoscopy, and the prep for these is going to be different, again, depending on the provider. Kind of like when we talked about upper GI, each physician has a different set of preps that they do. Sometimes the client will be NPO for a day beforehand, like NPO at midnight, and they'll have to drink like polyethylene glycol, which is Go Lightly. Some of them have to do mag citrate, and some clients have to be on clear liquid for a couple days before this. So it just really depends on the provider and their preference. Pretty consistently, though, you'll see clients that have to be NPO after midnight, and they have to drink some type of laxative to clean out their bowels. So the goal here is to prevent and control metastasis. Clients could undergo radiation or chemotherapy, so make sure you're referring to the oncology section when we're speaking about chemo and radiation. And then surgical management is going to depend on a lot of different factors. When you saw that picture of the bowel, it depends on where that tumor is located, so on what type of surgery they would end up having. They could even potentially end up with a colostomy, and that can be temporary or permanent depending on the amount of bowel that's removed. So here we have a stoma or a colostomy that is going to be on the right side in the ascending colon, and that's going to be for right-sided tumors. This one here is the transverse. There are two stomas here, so two colostomies are here, and this is typically reserved for emergencies, so think about your perforation and things like that. So one of these stomas is going to be where the stool is released from the body, and the other one is going to be mucus. Descending colostomy, that's going to be for the left side tumors, and the sigmoid is going to be for rectal tumors. Keep in mind that there are other disease processes and disorders that could potentially result in your patient having a stoma and a colostomy. The care associated with this and what you should be seeing with your stoma is going to be consistent despite the reason for the ostomy. So for stomas, they should be reddish pink and moist. And what we don't want to see here is a stoma that has recessed back into the abdomen, or one that has telescoped out, if it's purplish in hue. So make sure that you know what your stoma should look like and what it shouldn't look like. If it turns a different color, or it telescopes out, or gets retracted back into the abdomen, that's considered an emergency, and you would need to let the provider know. These should start functioning about 2 to 3 days post-op, and generally speaking, the provider is going to be rounding pretty frequently on these clients. But if for some reason you notice that they're not passing any gas and there's no stool, because they do pass gas from the stoma, make sure that you notify the physician. And they should also be having some bowel sounds too. It might take a little bit of time for their bowel to wake up because of the abdominal surgery, specifically on the bowel, but it should be returning. So when we're changing their appliance, we want to make sure that we're cleaning the area, removing the appliance. We don't want to use lotions around the skin because that's going to affect how well the apparatus adheres to the skin, including baby wipes, because baby wipes have a lot of moisturizer on them, so we need to make sure we don't want to use those. And then we're going to measure it. So stomas usually typically start out pretty large, and they shrink over time because there's some swelling associated with that. Just think about anything that has trauma. You're going to have edema, and these will have edema too. So it's not unusual for them to shrink. So we want to make sure that we're measuring them every time to make sure that we're using the correct size appliance for them. For the appliance, there are so many different varieties of appliances out there. There are some that you have to cut, some that are moldable. So the key is here to make sure that you have it a little bit larger than the stoma, because the harder ones, the hard ones that you have to cut, will actually cut into the stoma and cause injury. So you want to make sure that they're a little bit wider, but not so wide that you end up getting stool on the skin. And again, there are a variety of different types of appliances out there. I could probably name off a couple different brands to you. The key is if your client is having issues with their appliance adhering or something is going on, they have skin breakdown, make sure that you're consulting a wound care ostomy nurse. They should be rounding on these clients anyway. And the other thing is a lot of these companies will send out free samples, and that way the client can determine what works best for them before they go out and purchase a lot of really expensive products, because they are quite expensive. Skin protection, there's barrier sprays that you can use. Sometimes you'll need ostomy or stoma powder, depending on if there's like a fungal issue going on. So make sure that you're doing a thorough assessment there, and that you're involving the client in the care, because we don't go home with them, so we have to teach them how to take care of it. And then, of course, dietary measures. So depending on where their stoma is going to impact what they're able to eat and what they're not able to eat. It also impacts the way the stool looks. So if it's like an ileostomy, it's going to have high output and it's going to be very liquidy. If it's a colostomy, it's going to be more solid. It's going to look more like fecal matter, like what we would expect. So make sure you prepare your clients for that as well. Also make sure that they do know that they are going to pass gas from here, and it is going to sound very similarly to what they would expect, but there's really no control over it. So same thing with the fecal matter that's coming out. It's going to come out whenever it's there. So flatus is normal. We do suggest certain types of things for them to avoid, like vegetables that are gas producers, like asparagus and cabbage. And then they also have some that appliances that will have little filters on the back that'll help with that. The key is here to make sure that you burp these, because the gas will fill this up like a balloon and they can pop. So we want to make sure we burp them often. Okay, IBS, irritable bowel syndrome. Pretty common in the United States with 1 in 5 people. And this causes chronic or recurrent diarrhea, constipation, abdominal pain, or bloating, or all of it. So they could have, IBS with diarrhea, IBS with constipation, or a mix of both. Etiology here is unknown, but there's a lot of contributing factors that could include environmental agents, food, caffeine, carbonated beverages, dairy. Could also be immunological, genetic, hormonal, stress related. Typically, this starts in young adulthood and continues throughout life. And women are 2 times more likely than men to have IBS. So when you think about this, it could really be hormonal driven. We're going to focus on education here. So dietary fiber, 30 to 40 grams. And we want to help bulk up the stool to produce a more bulky stool and help regulate elimination patterns. And that can help to train the bowel as well. They could also add Metamucil or fiber bars or cereals if they have a hard time getting enough fiber. We also want to encourage them to drink a lot of fluids, so 8 to 10 glasses of water. And they may require bulk forming or anti-diarrheal agents, just depending on what type of IBS they're experiencing. Drug therapy is going to be symptom specific, so it's really going to focus on what is occurring with that particular client. If they're constipation dominant, they're going to go towards more of the Metamucil. So they're going to go towards more laxatives. And there's a newer one out called Linzess, and that is a water absorbing laxative that also stimulates bowel movements. And I believe Linzess also helps relieve any type of IBS associated cramping. IBSD, or the one that's more diarrhea prominent, may be treated with antidiarrheals such as loperamide or psyllium, which is a bulk forming agent. Complementary therapies are going to include probiotics, and that's to help promote gut health and prevent bacterial overgrowth. Stress management, relaxation, and yoga have also shown some promise. Moving on to hernias, these are caused by a weakness in the abdominal muscle wall, and that is allowing a section of the bowel to protrude. And it can also be another anatomical structure as well, not just bowel. In this case, we've got a bowel, and they have different subclassifications to these as well. So some hernias are reducible, meaning that they will retract back into the abdominal cavity, or the provider can push them back in. They could also have clients wear a truss that pushes them back in. And if they're not reducible, they're called irreducible, and that can lead to an incarcerated or strangulated bowel. So if you can imagine, if this is strangulated, it's kind of like putting a rubber band around it and you're not getting any blood supply. So if that happens, it's considered a medical emergency and it requires immediate intervention. With hernias, the inguinal hernia, which we see one down here, is going to be the most common, and those typically occur in men. For hemorrhoids, we have an unnaturally swollen or distended vein in the anorectal region, and this is caused by intra-abdominal pressure, which causes increased venous pressure. So you'll see these a lot with pregnant women, or even women after pregnancy, or women that have had a number of pregnancies. Obesity can also lead to this. And then I think of like weightlifters, like extreme weightlifting. So people that exercise strenuously. And this can also be caused by severe constipation and straining. They can be internal, like we see here, and they can also be external where they are visible. Sometimes the client will complain of itching. Sometimes there will be bleeding. And they're pretty common, but they're not concerning unless they become painful or there's a lot of blood coming from them. So some things that will help with this are going to be a fiber-rich diet, increased fluid intake, avoid straining, maintaining a healthy weight. Think about everything that causes this. Treatment includes cold packs applied to the anorectal area, sitz bath, so a tepid sitz bath, and then there's topicals that they can use as well, and over-the-counter medications. Most commonly, you think about Preparation H. Witch hazel is another one that will help with that. And then if it's severe, the provider may recommend stool softeners. Clients that have severe symptoms or severe pain, the doctor may prescribe oral analgesics, but just keep in mind that that's going to cause even more constipation. If they're pretty symptomatic and having a lot of discomfort, they may even have to undergo a hemorrhoidectomy. Malabsorption syndrome, this is going to be associated with a variety of different types of disorders and intestinal surgical procedures. So think about like gastric bypass, they're going to have a malabsorption issue. Can be caused by inflammation, intrinsic disease, and injury to the lining of the intestine when we're talking about surgeries. So we're going to have a limited absorption of nutrients, and that's caused by bile salt deficiency, enzyme deficiencies, obstruction, and ischemia. Some causes of this are going to be pancreatic disease, liver disease, Crohn's, and celiac. For assessment, your client may be suffering from chronic diarrhea or stearrhea, which is the oily stools, weight loss, bloating and flatus, decreased libido, easy bruising, anemia, bone pain, and edema. So just think about that when we were talking about different things with fluid and electrolytes. If they're having chronic diarrhea, they could be having issues with fluid volume deficit, fluid and electrolyte imbalances, and even an acid-base imbalance. So all of these symptoms are going to cause other issues. You may see that these clients have a decrease in mean corpuscular volume, their MCV, their mean corpuscular hemoglobin, MCH, and mean corpuscular hemoglobin concentration. And those are all going to be signs of microcytic anemia, and that is resulting from iron deficiency. So we talked about that in the fluid and electrolyte week, or in the oncology week even, where when they have that microcytic anemia, those cells are pretty tiny. And that is a result from iron deficiency. These clients are also going to have low protein and low albumin and low cholesterol, and that's from decreased absorption of fats. So nutrition is really going to be a focus with these clients. For interventions, we're going to avoid any aggravating substances, so alcohol, fatty diets, caffeine, and dairy. They may need enzymatic replacement, water-soluble vitamins like vitamin B complex and folic acid, and then the fat-soluble vitamins A, D, and K. For minerals, they may need calcium and magnesium. An additional drug therapy may include antibiotics, antidiarrheals, and anticholinergics. And the anticholinergics like Bentyl are going to help inhibit gastric motility. You want to monitor for fluid and electrolyte imbalance, acid-base imbalance if they're having a lot of diarrhea, and then surgical management of the primary disease. So your interventions are going to be focused in on the cause. Okay, so once again, that is our last slide for this PowerPoint. You may download the PowerPoint for the review questions. And this concludes Chapter 51, Concepts of Care for Clients with Non-Inflammatory Intestinal Disorders.